Good afternoon and welcome everybody to another Spiegel and Theis webinar, as always broadcasted here in Overath, close to Cologne in Germany. My name is Matthias Geuter and it is my pleasure of hosting today's webinar that will contribute to our BET webinar series that we launched early last year in order to share as much information, knowledge and expertise within our BET community. During our last webinar in November 22, we had the privilege of listening to the two godfathers of BET. We were listening to Professor Zuthoff from the University Hospital in Bielefeld and to Professor Poe from the Harvard Medical School in Cambridge, Massachusetts. Both speakers were talking about the pre-diagnostic, the general approach, and medical outcome of this technique. During that webinar, we also learned that the placement of a modern atraumatic dilatation catheter system is safe if performed correctly, which is why there is no history of any severe cases. We were also shown a very high level of efficacy and satisfaction, especially among children and barrel challenge patients. Surveys have shown that more than 93% of all barrel challenge patients would undergo that procedure again if needed, what to me is a clear indicator of a very high customer satisfaction. And then finally, we also learned that the occurrence of eustachian tube dysfunction, according to a US-based study, is 4.6% in adults and even higher in pediatrics. To us, that was a good reason to dedicate today's webinar to a very special clientele, pediatrics, our youngest and most precious patients. All right, so our today's speakers are Dr. Sara Euteneuer from the University in Heidelberg and Professor Matthias Tisch from the Military Hospital in Ulm. With well over 1,000 catheter placements, these two speakers have contributed to this innovative way of treating eustachian tube dysfunctions in children, where it has become an established procedure in modern hospitals. Dr. Sara Euteneuer will first talk about optimizing eustachian tube function in children to prevent the ear diseases in adulthood. We will then listen to Professor Tisch, who will share within his presentation real cases and videos and will talk about all his experience that is required to do a proper catheter placement. Last thing, before I hand over the microphone to Dr. Euteneuer, who's already waiting for us in Heidelberg, if you do have any question, please use your Zoom chat option to submit your question. All questions will then be addressed towards the end of this webinar. So please enjoy the next two presentations, and I will see you in about 1 hour. Thank you very much.
Good morning, Americas. Good afternoon, Europe. Good evening, Asia. It's my pleasure to be able to talk to you today about eustachian tube dilatation in children. And I extend my very grateful thanks to Spiegel and Theis for inviting me this afternoon, this morning, tonight, wherever you are, for this presentation. And it's a great pleasure to join this presentation with Professor Tisch, whom I know for more than a decade by now, since he has a teaching affiliation with Heidelberg University Hospital as well. So we're seeing each other regularly. And without Professor Tisch, I would not have embarked onto eustachian tube dilatation and not even in children. So it's a great pleasure to do the presentation for you today. Let's start with it and I'll share my screen. All right, how did I get to eustachian tube dilatation in children? Well, by training and by my main workload during my day, I'm an otologist, an ear surgeon. And if you are running a specialized ear clinics as well, you all know these patients that had problems with their ears in early childhood, like recurrent acute otitis media, then had many grommets inserted, and by the age of 10, 11, 12 had their first tympanoplasty, and then they had their recurrences, and really their ears have been a lifelong theme for them. And finally, the hearing loss progresses, and you're still dealing with cholesteatoma or retraction pockets. So that really led to the motivation in myself to change that picture or change that game and try to optimize eustachian tube function early on in childhood. I have to disclose that at the ENT clinic, which you're seeing on the picture, I am the local PI for a study funded by Cochlea on bone conduction hearing aids, and I'm the local PI for a multi-center study with Med about cochlear implantation. And I have received support for local and national meetings by Med and Cochlea, and in addition, advanced bionics, and of course, Spiegel and Theis. All right, thinking about eustachian tube development. These pictures are taken out of the Bluestone textbook. And usually we all thought that the eustachian tube matures by about the age of 6 to 7 years. And in the infant or in children, it's more horizontal, it's shorter. The osseous part has a huger part, and as it matures, the angle and the length change, but it is not only that. The whole surrounding and structures change as well. Our knowledge about eustachian tube development for more than a century has come from histologic sections. This is one of the earliest I could find from the famous Professor Politzer from 1901. And as I mentioned already, in children, the eustachian tube is shorter. It's more horizontal in plane. The lumen is smaller. The volume of the cartilage around it is less in children. However, the density of the cartilage is greater. The elastine portion in the cartilage is less, so it's a little stiffer. And the Ostmann's fat pad is wider, is thicker. And it has more mucus folds and various amounts of glands. And the middle ear lumen, where it leads to, is smaller than in adults. Important for eustachian tube dilatation, taking a step further and thinking about the catheters we are using, we for sure have to look into more detail regarding the eustachian tube length. And once again, there's basically two methodologies to look at eustachian tube length or to study it. And there is histologic sections, and I brought you the one from Ishima from 2000. And I will show you recent CT scan studies. So basically, in these histology study where they looked at children of various ages that had passed for various reasons unrelated to eustachian tube, they saw that the cartilaginous eustachian tube, that is the area of the eustachian tube where we want to do the dilatation, not the bony part, so that the cartilaginous part starts at about 18 millimeters. And then already by the age of 4, it has progressed to 20 millimeters, which is the active length of the Spiegel and Theis catheter. And then matures to about 30 millimeters or little shorter than that. Important, the cartilaginous portion in the smaller children is the larger part than compared to the bony part. So the growth is really happening in the bony part. Then let's look into the radiology studies. I pulled 2 of them from 2001 and a very recent one. And when you measure from the torus tuberous in the nasopharynx, which you are seeing when you're entering balloon catheters into the eustachian tube, to the bony isthmus, once again, at about 2 years of age, the length is about 20 millimeters. And once again, that's the cartilaginous portion. And then it matures to about 27 millimeters up to 30 millimeters in the adult. This is the ranges. But you can once again see at about 5-6 years, even looking at the ranges, you are above the 20 millimeters from the Spiegel and Theis catheter. The Spiegel and Theis catheter, the regular length is shown down here, where they measured the length of the catheter in a current study. And I show that picture to you in conjunction with the length of the cartilaginous tube, because it hints to something important. So the active length of the catheter is 20 millimeters. However, it still has another 4 millimeters in front of the balloon, so the catheter tip. And when you use the designated application or insertion device provided by Spiegel and Theis, there's about another 7 millimeter that are non-inflated, that the balloon kind of protrudes anteriorly. And if you calculate that all in at once, altogether, you are at about 38 millimeters. And when you look back at these numbers over here, then basically you would not be in the cartilaginous part of the eustachian tube anymore, and you would be entering the bony part. And in the study by Treppel et al., they even saw the catheter protruding into the middle ear. From my point of view, that is something that is in your hands as the interventionalist or as the surgeon. So when you insert the catheter, especially in children, you want to make sure that you see that hint tip of the active balloon on the nasopharyngeal side. So you don't want to push that catheter all the way so that you basically can't see it anymore into the entrance of the eustachian tube. So when we discuss safety later on in the discussion, possibly, I really want to emphasize that it is in your hands as the surgeon. One thing in the table for the eustachian tube development that I have not mentioned yet is the nasopharyngeal opening of the eustachian tube. And that is basically when we have to talk about adenoids. This is a look into a right nasal cavity. And what you can see here is the posterior septum, the choanae. Here you see the completely closed or compressed entrance of the eustachian tube, and the torus tubarius, which is basically lateralized by a huge adenoid formation that leaves a little bit of air for breathing for that child, but leads to compression of the eustachian tube. And it not only has the capability of mechanically obstruct the entrance of the eustachian tube, but it leads to a chronic source of infection. So basically in kids with adenoids like this, you have a constantly running nose, one respiratory infection after the other. And once again, that's a stimulus for the lymphoid tissue in here. And you kind of end up in a working circle. So the chronic infection leads to the hyperplasia, and things are getting worse. So this is why I strongly believe that adenoids should be taken care of before you take further steps towards eustachian tube treatment, i.e. balloon dilatation. So adenoids first. Why do the adenoids have such a deleterious effect on middle ear ventilation on the eustachian tube? It's not only that chronic source of infection, and it's not only the mechanical obstruction for the eustachian tube, but if you look at that child, these children usually breathe via their mouth. Thereby, the mouth dries up and there is no need to swallow the salvia. So there is less swallowing and therefore less opening in vents for the eustachian tube. And the dry skin leads to even more respiratory infections, which once again leads to lymphoepithelial reactions and possible hypoplasia of the adenoids. And as you see in that child, the tongue is not resting against the maxillary bone. So if you close, if you feel into your mouth as you're sitting in front of the screen, your mouth is closed, your tongue is resting on the maxilla. And if you now open your mouth and let your lower jaw hang down, you can feel like your masseter muscle is relaxing. So after adenoid surgery, I really encourage parents of children to be after the children, so that after surgery, once they can breathe via their nose, they really close their mouth so that the tongue gets to rest against the maxilla, and that leads to the widening of the maxillary bone that we need during development. Because if you really look into detail about of the opening mechanism of the eustachian tube, and Professor Poe has done that nicely in the first seminar of this series, you will know that you need that wideness within the maxillary bone so that the opening muscles can work properly. So if one looks into various multi-center studies in various reviews and in the guidelines from various societies, basically adenodectomy is the most beneficial in children with chronic middle ear effusion over the age of 4. And when you look at huge numbers of children and you look into the treatment for a chronic serous otitis media, and for recurrent acute otitis media, there's definitely an advantage in a primary adenodectomy if you want to compare them with tubes as compared to tubes alone. So once again, the adenoids really have to be taken care of. And I talked to you about the wideness of the maxillary bone. And with the children, I really encourage the parents to have a look that the mouth is closed, that the mouth widens up. And I recommend the parents to see a maxillofacial surgeon or their dentist at least, so that he or she can have a look at the kid's mouth. In this picture here, you see that the narrowness of the maxillary bone can cause issues with dentation, basically that there's not enough space for teeth. But even if there is, that side doesn't look too bad, there might be the indication for help in that maxillary expanding the maxillary bone during development while it's still sensitive. And I pulled up these 3 studies for you. Basically, it's studies on children with chronic serous otitis media and the concurrent conductive hearing loss. And after the rapid maxillary expansion therapy, 8 months thereafter, all these kids who had their effusion, who had their hearing loss, restored in their eustachian tube function, had no hearing loss anymore, and had all type A tympanograms. Same in other studies, once again, chronic effusion kids with their conductive hearing loss. And in a control group where they were just watched, in a group where they got ventilation tubes, and in a group where they had the rapid maxillary expansion, the hearing improvement was better in the rapid maxillary expansion group even in the VT tubes. Same in the last study. I strongly encourage you that after an adenectomy and you see the kid back, look at the growth of the maxillary bone and try your best so that it widens as it should. And if you think back at your otology clinic, at the adults with the chronic eustachian tube dysfunction, there's quite a bit of folks that really have these narrow maxillary bones. So take that in consideration in the kids, where you could still easily expand the bone to the width that it needs. Having talked about the nasopharyngeal opening of the eustachian tube, we should look at the middle ear opening of the eustachian tube as well. So the eustachian tube itself is lined by the same respiratory epithelium that we find in the nose, in the sinuses. And in the middle ear, the area around the opening of the eustachian tube has that very same epithelium as well. And otherwise, the middle ear cavity is lined by a single layer epithelium that does not have any stereocilia. I'd like to emphasize that whenever there is acute otitis media going through a middle ear cavity, or when there's a chronic effusion that is not that very thin effusion, but it's really a mucus effusion, that there is something going on in the middle ear cavity itself, and it will leave its trace. So in my hands, if the child, or the reason for presentation of the child, is chronic otitis media with effusion and it lasts more than 3 months, and it usually comes with the conductive hearing loss as well, maybe even speech development is delayed already, I do at least a paracentesis, and if the mucus that comes out is really thick, then I put ventilation tubes to make sure that that paracentesis doesn't heal within the next couple of days, but that the ventilation tube kind of stents the paracentesis so that air from the outer ear canal can come to the middle ear cavity, and that the mucosal reaction can really calm down. It was my pleasure to be involved in middle ear inflammation studies before I gave birth to my own kids back 15 years back from now. And my colleague Anke Leichtle, whom I worked with at that time, published a recent paper on mouse models about acute otitis media, and it's worthwhile to have a look at. And it's exactly what I told you. So as in humans, in the mouse, it's a single layered epithelium, and if there's no bacteria, no infection going on, it's that small single layered. And if you inoculate non-typable Haemophilus influenza into the middle ear 2 days after you did so, there's a real actual hyperplasia going on, and that becomes less over time. But as you see here, that epithelium looks different like this one. And Professor Pohl mentioned it in the first talk already. This altered epithelium alters the oxygen absorption in the middle ear, and it facilitates not only over the via the oxygen absorption, but via the mediators, the possible progression of retraction pockets and cholesteatoma formation. So with all the treatments in the nasopharynx and to the eustachian tube, the real goal is to keep that middle ear healthy, to make sure that it has as little acute infections as possible, and that the that the effusion lasts for the fewest time amount possible. Then we have to talk about allergy and its impact on eustachian tube function. With the adenoids, I already talked about the lymphoepithelial reaction, and allergy plays into that as well. So as it's normal for children in the preschool age that viral and bacterial infections just occur. It's needed because it helps to build our immune system. Their innate immune system will already react. It will release cytokines and local mediators. It will lead to the nasopharyngeal inflammation that will then impair eustachian tube function via the swelling of the mucosa. It will lead to under pressure, and it can lead to acute otitis media. And once again, allergy with those mediators accelerates this process. I like to show you one quite old study that emphasizes on this. So basically what they did, they looked at 10 patients, so 5 years, and they either had allergic rhinitis or not. The allergic rhinitis diagnosis was done by specific IgGs and clinical findings. And what they then did was a nasal provocation with either a negative control or with histamine. And then they did a 9-step tubomanometry. So basically they looked at eustachian tube function really thoroughly. And they did a rhinomanometry. The results were that in the 10 years of the allergic rhinitis patients, they started to have eustachian tube function at very low concentrations of histamine, while in the control group, only 2 out of 10 years had eustachian tube function at relatively high doses of histamine. So the allergic reaction people were much more sensitive against the histamine provocation. And it was eustachian tube function that reacted first, and they couldn't see any differences in the rhinomanometry that they did afterwards. So when there is eustachian tube function, even in children, I'd really like to encourage you to look for an allergic disposition and not to miss it. And new studies hint that the intradermal testing might be really superior to pick up allergic dispositions in eustachian tube function than the regular skin testing. Another thing we should talk about in children is reflux. And here you recognize a name that is well known in eustachian tube balloon dilatation, Holger Suthoff, who invented the first specific dilatation catheter with spigelin ties, and it was my pleasure to work with him nearly 2 decades ago. And by then we looked at gastroesophageal reflux, actually, which we should say extraesophageal reflux, and its association with otitis media in children. And since then, many studies have come up that were able to show that the gastric protein pepsin can be found in middle ear effusions in children as well as in adults. Problem or the question always is it really gastroesophageal reflux related disease? And the gastroenterologist will tell you that it's basically the presence of symptoms related to the passage of the gastric contents from the stomach to the esophagus and beyond. And besides the middle ear effusion that you're seeing in the children you want to treat, please ask for other symptoms like visible vomiting or frequent regurgitation or heartburn in the kids. The teenagers will be able to tell you about heartburn, and in the smaller kids, you'd really need to ask mom or the other caregivers about this. Another hint for reflux going on might be recurrent pneumonia or asthmatic symptoms. And if the caretakers admit on any like this, it makes sense to ask about feeding patterns for the children. And sometimes there's already very kind of little tricks that would change the game and take reflux out of the game as a risk factor for eustachian tube dysfunction. To sum this part up, in my hands, diagnosis comes first, and diagnosis of eustachian tube function in children really depends on the history and on the physical examination. And the physical examination is not only the look at the ear to see the infection or the chronic effusion, but I'd like to encourage you to try your very best to examine the nasopharynx of the child. If you make a game out of it and take the help of a local anesthetic, it's already possible to do a rigorous endoscopy on a 5 or 6 year old. It really needs to be a playing game, but then you will be able to see very much. Then allergy testing, if anything hints to it. I sometimes do a general IgE in the kids to look for an allergic disposition. And then from the apparative testing, it is just a tympanogram or an age-appropriate hearing test to pick up the conductive hearing loss. When you see the hearing loss or the acute otitis media and you're suspecting chronic eustachian tube dysfunction, I'd first recommend conservative treatment. And there's definitely still a place for ventilation training and still off-label nasal steroids, because that really acts on that lymphoepithelial reaction and not hyperplasia, and on that hyperplasia going on there. And in line with many societies' surgical recommendations, I would recommend first-line surgical treatment in disease or symptoms that's going on for more than 3 months. And the first step will be the adenoid removal, joined by a paracentesis and ventilation tubes if needed. As you see, I'm not seeing the balloon dilatation just there, but in the children, so far in the children that have failed that first line treatment. So basically, when after 3 months, which is the time frame for surgical interventions, there is still chronic otitis media going on, or the child has recurred in acute otitis media, then as a second line treatment, so when you make your second decision for surgery, that's where I definitely see the time for eustachian tube dilatation, once again with a paracentesis, and if needed, I'd put ventilation tubes as well. Conservative treatment definitely is worth a while. So it favors treatment on the nasal balloon studies. We love them here in Germany. Every child, nearly every child that I scheduled for surgery has had their Tubavent balloon and really try to inflate that balloon. So basically do a playing game to perform with the salvas. And if we then progress to bed, in addition to the adenoid removal, to the paracentesis, so what might be the possible action? Professor Poe, not in the first series of this seminar, but elsewhere worded it that the eustachian tube dilatation is kind of the adenoidectomy of the eustachian tube. Where does that come from? There's basically one study that looked histologically at what is happening after balloon dilatation of the eustachian tube. And what they basically saw is that this lymphoid infiltration below the mucosa is kind of crushed during balloon dilatation, and that leads to scar formation in the submucous tissue and a reduction of the lymphoepithelial load within the eustachian tube. Another possible mechanism that's what I'm thinking of when I'm doing the balloon dilatations, is that in adults as well as in children, when the balloon catheter is inserted, it's inflated. I always see, or nearly always see, a really kind of fluctuation in a soft palate. It looks like there's really kind of pressure spots hit, so that the muscles that work on the eustachian tube are reacting as well. But there is obviously no studies for or against that. So the first reports about balloon dilatation with the designated Spiegel and Theis balloon came from Holger Suthoff's department from Bielefeld in Germany. That publication is out of the year 2010. And as early as 2013, Professor Tisch reported about the first dilatation in children, and I'm really looking forward for his second talk where he'll tell more about his experience. With that publication presented to the German otolaryngologic community, a kind of really rocked the scene, I would say. So we really, the ones of us who had been in doing the eustachian tube dilatation in adults were really seriously considering from that point on taking the dilatation off label to the people below 18 years of age. And we started on dilatation in children as well. So if you are beginning with balloon dilatation, I would strongly recommend that you do 100 adults first and make your experiences, and that you then embark on the 5 or 6 year old. Because you really want to do it in a safe measure. When we saw, or there's very little prospective studies on eustachian tube dilatation around. There is studies from the US for the licensing of the competitors' balloons, but there's no real prospective studies in children just yet. So back in 2014, and it took an amazing amount of time to get the paper published, we joined with 9 German departments, once again, the usual suspects, Professor Tisch and myself, and joined the data, pulled together the data on the children we had done by balloon eustachian dilatation so far. Altogether, we had 176 children with 299 ears. As I stated, in my management protocol, they all had recurrent disease. They all had adenoidectomies first. The mean age was 9 years, and basically the range was really narrow about these 9 years. When we looked at why we had offered balloon dilatation off-label to the parents of these children, it was basically 2 reasons. It was tympanic membrane retractions, kind of bordering the need towards tympanoplasty, and it was recurrent chronic effusion, once again after previous intervention, so really recurrent disease. When we then looked for the indications and we really picked out the chronic effusion kids, it was 66 children, 105 ears. They all had recurrent infusion, and they all had type B tympanograms at the time of balloon dilatation. They were slightly younger than the average in the cohort. They had a mean hearing threshold, conductive hearing loss of 25 decibels before, and only 10 decibels after surgery. And when you look at the tympanic membrane appearance after the procedure, we saw out of these 100 ears in 65 ears normal tympanic membranes. Only 20 kids still had their chronic otitis media, 12 had reactions, 1 had progressed to cholesteatoma. Since we were allowed to do additional procedures to the middle ear, we found 4 ventilation tubes and only missed 3 for follow-up. If you're interested in the whole study, it's published in Otologia and Neurotology a little more than a couple of years ago. So in summary, for my treatment algorithm in eustachian tube dysfunction in children, really look at the kids. Look out for risk factors like allergies and possible reflux. Try conservative treatment, at least give it a chance for up to 3 months, ventilation training and nasal steroids. And if the nasopharynx still looks like this and the child is still symptomatic from the ear, so basically there's still fluid behind, then as a first line treatment, remove those adenoids, do a paracentesis, and if needed, put a ventilation tube. Then follow up with the kids for at least another 3 months. And if you see the recurrent disease, then please think about eustachian tube balloon dilatation in kids as well. And don't forget the structural anatomy of the kid. Think about the maxillary bone as well. And with this, I'd like to thank you very much for your attention, and I will hand over right to Professor Tisch, who will present you our results on eustachian tube dilatation, the kids in even more detail. And then the two of us are very happy to take your questions all together.
Thank you, Sarah, for your presentation and for underlining the importance of early intervention in young patients to prevent ear diseases in childhood. My name is Matthias Tisch. I am the Chief Medical Officer ENT at the Military Hospital in Ulm, and I'm very pleased to share my experience in tuboplasty, particularly in children with dysfunction of the eustachian tube, with you today during this webinar. Research into the cause of dysfunction of the eustachian tube goes back a long way. In 1835, Antonio Maria Valsalva, he was the first to describe the eustachian tube. In 1862, Joseph Toynbee published findings on the tube, and important further groundbreaking and pioneer research on the function of the tube was published by Politzer in 1920. Toynbee was the first to find out that the eustachian tube is closed under normal conditions and opens only when chewing, swallowing, or eating. His studies were crucial for the physiological as well as the pathophysiological understanding of the eustachian tube. Looking at the anatomy of the eustachian tube, which will be discussed below, we see that the tube is the connection between the middle ear, you see here the eardrum, and the nasopharynx. The length of the eustachian tube from its opening in the nasopharynx into the middle ear varies between 3 and 4 centimeters. As mentioned earlier, the eustachian tube is usually closed and opens only when swallowing, eating, or speaking. These brief milliseconds openings are critically responsible for keeping the eardrum in a normal position. If there are dysfunctions in the area of this opening and closing movement, the eardrum may retract or bulge and the ear pressure may develop. The question is, what are the problems that can arise from a tube dysfunction? This is, of course, initially a pressure equalization problem of the middle ear and the mastoid. The consequence of the malfunction of the eustachian tube can be pressure problems and pressure sensations in the area of the middle ear, hearing loss, or also recurring middle ear infections up to chronic middle ear infections with a dramatically increasing risk of cholesteatoma. So what are the diagnostic steps that can be used, especially in children? This is the Toynbee and the Valsalva maneuver in older children, of course, the basics of audiometric diagnostics, such as in particular tympanometry. In special institutions, in special clinics, as in my clinic, there is a tube manometry, or of course, radiological procedures with which anatomical dysfunction, such as tumors, can be detected. Here in this slide, you can see the ideal findings of a normal tympanometry with a peaking curve. And in the next slide, you see it's like different. Here you can see a curve with a maximum flattening, which suggests a tympanic effusion, but does not necessarily represent the malfunction of the eustachian tube. There are different ways, of course, to optimize or restore a disturbed tube function. In principle, conservative measures are possible, in particular, local cortisone spray, so mometasone spray. Among these, reduction of the adenoids can be achieved, and in addition, an improvement of the drainage function of the eustachian tube with the aim to ventilate the middle ear again, so just like grommets. So in this slide, you see that you can use grommets as a long-established treatment options, and there are different kinds of grommets, and they all are working fine. Tuboplasty has progressed rapidly since its development and is now used thousands of times a year. It's a very safe procedure with a high success rate. If one looks at the literature, a large number of different studies have been presented since 2010, also on medium and long-term success rates. Success rates between 60 and more than 90% have been reported. But to be honest to you, it is fundamentally inconceivable that simply inserting and dilating the eustachian tube with a catheter will result in such sustained success. So the question is, why does it work? And nowadays, there are three theories which I would like to present to you now. The first theory comes from the working group of Professor Sutov, who was in charge of developing and introducing this method. He saw in cadavers, or in cadaver preparations in the beginning, a tear in the cartilage of the eustachian tube, and was therefore of the opinion that through this cartilage tear theory, it comes to a change in the area of tension of the cartilage, and thus to a permanent improved opening of the ear cartilage of the eustachian tube. While this is possible in principle, I don't think, for me, in my opinion, that it is very likely. The second theory that has become established in the literature is the change in proprioceptors in the muscles of the eustachian tube. Analogous to a physiological exercise, there is a change in muscle tension due to activation of the proprioceptors in the context of tuboplasty. This could lead to a higher tension and thus to a better opening situation. In my opinion, I think the theory that the catheter removes adhesions in the area of the eustachian tube is much more likely. Due to the tubal tonsil, first described by Bluestone and Coburgers 2005, and its infectious effect, adhesions and scarring occur in the area of the pharyngeal orificium of the eustachian tube. This can be ruptured and removed by inserting the catheter and dilating it. I think that this is improving the secretion transport and the drainage. I consider this to be the most likely of all theories, also in view of the fact that when the catheter is withdrawn, a block of accumulated mucus is often removed at the same time, and I will have a video to show it to you afterwards. If we look at the situation of children in terms of anatomy, we cannot help but notice that there are a number of differences compared to adults. In children, the eustachian tube is much shorter. The eustachian tube is not approximately full grown until the age of 7, and it has a much narrower lumen. In addition, the ankle of the eustachian tube is running much more horizontal, only 10 degrees, whereas in adults, the ankle is almost 45 degrees. This will and may be a reason for the significantly easier extension of germs and the more frequent occurrence of middle ear infections. In addition, it also Ostmann's fat body is thicker, cartilage volume is lower, elastin is less abundant, compliance is markedly increased, and the mucosa has a much higher immunologic function due to its thickness and much more pronounced convolutions. So in children, these anatomical variations are not present in that form. This may be an explanation for the other immunologic function. In children, the drainage function and ventilation via the eustachian tube is significantly reduced, and a large number of recurrent infections occur. In addition, the function of the tensor veli palatini muscle and the levator palatini muscle, the two muscles for the tube, is not yet as pronounced, which makes the drainage function of the eustachian tube much more difficult. Now, with all these obvious advantages, one wonders why there was no basic recommendation for performing tuboplasty in children, especially in the beginning. It is obvious that the majority of problems caused by eustachian tube dysfunction develop in adolescence and adulthood. I'm thinking in particular of cholesteatoma or adhesive processes. If one were to ensure that these problems did not arise at all in childhood, one would not have to deal with these consequences later on. The reason that tuboplasty was not recommended from the majority of the guys who worked with that was the fear of getting a bleeding complication of the internal carotid artery. In addition, at the beginning, it was thought that the catheter regularly provided from the company was not suitable for children because it was too long. This, of course, is also absolutely incorrect. As already explained, from the age of 7, the length of the eustachian tube in children is comparable to that of adults. Furthermore, it must be kept in mind that in younger children from the age of 2, when we start with the tuboplasty, the eustachian tube is shorter, but, and this is the most important point, the ratio between the cartilaginous and the bony part is 8:1 and not 4:1. Thus, if the tuboplasty is performed correctly, it is almost impossible, absolutely impossible for the catheter to enter the bony canal even in young children. So what are the contraindications for tuboplasty in children? It should be pointed out, of course, here that the absence of pre-treatment, no pre-treatment. I was talking about mometasone spray or other conservative measures, and a lack of anatomical orientation. The absence of anatomical landmarks are absolutely contraindications. In addition, there are relative contraindications such as in particular children under 2 years of age, a condition following skull base fractures, tumors, or also bleeding abnormalities. In these cases, the indication for tuboplasty should be given very cautiously. When we focus, as with all surgery interventions, diagnostics are crucial for correct performance and therapeutic success. Correct diagnostics consists of a complete history, especially of the parents, an ear microscopy, an attempt to perform the Valsalva maneuver or the Toynbee maneuver, although this can be reasonably performed from the age of 4 at the earliest. The performance of a pure tone, a tympanometry, a complete endoscopy of the nose and also of the epipharynx, especially with regards to adenoids, as otherwise tuboplasty is extremely difficult or impossible. An orienting examination with regards to allergies, a nasal examination, and if necessary, imaging are also part of the complete diagnostics. Based on my experience, I generally recommend that the procedure should be performed under general anesthesia. Local anesthesia is not recommended in my opinion. In adults, there are some guys who do that. Personally, I have done 2 patients under local anesthesia who were not pain-free, which is why I now only perform the procedure under total intravenous anesthesia. A complete decongestion of the nose, also a cleaning of the nose to have a good view, are the conditions for good orientation to identify exactly the landmarks. Then you can place the catheter in the right place, insert the catheter, leave it for 2 minutes, and then remove it. This is very simple, and this is, in my opinion, the best situation. Keep it simple. As you can see in this picture, the insertion tip of the catheter here has been modified. It is now much more rounded than it was in the beginning. In the past, injuries to the mucosa had occurred, particularly in the case of severe scarring in the area of the entrance to the tube. If the patient sneezed or sniffed after the intervention, air was blown in via these micro injuries, which in itself is not a serious problem, of course, but which now occurs to a significantly lesser extent thanks to the modification of the catheter tip. The question of whether a catheter should be removed blocked or unblocked is always a controversial one, especially when inserting the catheter. You are coming in here, you insufflate the catheter is blocked, and then it's removed. You should believe that there are side effects when the catheter is removed in a blocked way. And when the catheter penetrates too deeply with the insertion device, the catheter could possibly be pushed through the middle ear, and the tympanic membrane perforation could even result. So we have observed a few of these cases in our patients. So let me explain the video. You see here now the left nose, you see here the septum, the inferior turbinate, and here is the epipharynx. When we start the video, then we are coming into the nose. Yes. Now you see here the region of the fossa, so the point of interest. The insertion tool is coming from the right side. Now we are looking via the 30 degrees endoscope on the left side. Here you see the fossa. Now the insertion tool is coming from the right. Now you see here is coming on. You switch the insertion tool, and just now it's in the fossa, and now you can bring in the catheter via the insertion tool. The question whether it's better to remove it blocked or not blocked is explained in the next situation. You see here Now the other side, the right side. Yes, the endoscope is on the right side. The insertion tool is coming from the left side. Now we have to wait until the 2 minutes are gone. The video is running, so it's a little bit boring, of course, but just now you will see why I want to focus on that situation. You see, it's blocked, it's blocked, it's blocked. Let me move. Let me move once again. Now, you see the catheter is removed, the insertion tool is coming back. And now, look to the catheter is blocked. So, via the pressure of the catheter, now you see all this mucus is coming out of the eustachian tube. I think this is why I recommend to bring out the catheter in a blocked way. What should be considered after tuboplasty? Of course, first of all, care of the nose with a dexpanthenol or saline solution and a decongestant nasal spray are the standard situation. Tube training should be started at the earliest after 3 days. This is related, among others, to the micro-injuries of the mucosa we have talked about in order not to get a risk of emphysema. And steroid you can start after 2 or 3 weeks. Antibiotic treatment is absolutely not recommended. There is one case. It's a 62-year-old man who had a both-sided ear problem for decades. This patient was one of our first patients. I think it was patient number 6. And all the conservative therapy attempts that had been carried out had not been successful. All the examinations performed beforehand showed inconspicuous age-appropriated conditions. The patient had a strong negative pressure in the tympanometry. And in the course of the performed tuboplasty, the mucosa was injured by the catheter. It was the old catheter, which was still used at that time. And when you look at this picture, you see after strong sneezing of the patient, this emphysema on the left side. This is a very impressive complication, of course, and it healed within a few days without any consequences. And nowadays it does not appear because of the modified tip of the catheter. The first child we treated was a 20-month-old female baby. It was presented to us in October 2011. At that time, it was a young girl who had been treated with antibiotics 14 times in the previous 12 months. 14 times in 12 months. She had undergone an adenectomy at 16 months of age and had no known allergies. We decided at that time to perform a tuboplasty, to try it, to change the situation. However, this was not possible in October 2011 because the adenoids had already grown again so large that anatomical orientation was not possible. So we performed once again a re-adenectomy and recommended local steroid therapy, mometasone spray, and arranged a new attempt for tube dilatation for tuboplasty in January 2012. By this time, 2 further middle ear infections had occurred once again. Then, after successful bilateral tuboplasty in January 2012, a nearly 3-year infection-free interval was successfully demonstrated. And to be honest, at last, I saw this patient 3 months ago. She's now 14 years old and has no more problems with the ears. So we also collected an evaluation of the tuboplasties we performed in children at that time back in 2011 to 2012. There were 105 children in whom 185 interventions were performed, 48 male, 47 female, 25 unilateral dilatations, 80 bilateral dilatations. Mean age of about 8.5 years with an age range from 20 months to 14 years. And 86 of our patients do not have any previous surgery, no tympanoplasty. 19 do have tympanoplasty before. And to focus to the results with a patient satisfaction, you see a very clear result of 105 parents survived, 95 reported being satisfied or very satisfied with the outcome, and there was no change in 10 patients. Comparable to the results in other studies, you see here the Valsalva procedure, and so you see 20 cases were able to do a Valsalva procedure before dilatation and 85 after the dilatation. So this is a very perfect result. In a further course, we then conducted a large quality control study regarding the results, and it was a questionnaire. It was sent to 1,325 parents with a participation by phone from 1,000. The mean age in this study was once again nearly 5 years. Youngest patient 20 months, oldest patient 12 years, and the mean follow-up was nearly 2 years. So repeated tuboplasty in about 158 of these 1,000 patients, from a range from 1 repetition in 75 up to 3 repetitions in 20 patients. If you look to the results, you see that no problems were reported by nearly 82% of the patients, and we had otitis media 3%, pressure 10%, pain 7%, and epistaxis 2.5%. So I think this is a very rare complications, and once again, extremely or very satisfied, nearly 80% of our patients, and 20% of our patients have not been satisfied. So what does we recommend in follow-up? We recommend a control examination after 1 and 8 weeks, redilatation at the earliest after 3 months. It is very useful from my point of view, especially if there was no success at the beginning, but you should not perform it too early. And in total, it must be assumed that about 20% of our patients with a tube dysfunction cannot be improved in the long term by either conservative or interventional therapy, and we do not know why. So there is no clear situation for this problem, but in the all in the population of this disappointed patients, we have a success rate of about 80%. So let me summarize. The most important point in tuboplasty, especially in children, in principle, conservative therapy should have been exhausted. This is the most important point. Nedenectomy is the gold standard, and the old plaster motto applies: first the nose, then the ear, or first the nose, then the tube. In the meantime, various methods have become established for performing tuboplasty. As already shown to you, we prefer the use of the 30 degrees endoscope and only one insertion tool, so we do not see any conditions for other tools. Especially with a little experience, it is sometimes difficult to have a good orientation, to intubate the tube, to be sure that you are in the right place. If necessary, this can be made more objective by using a pre-prolapsed tympanic membrane as part of a simultaneous ear microscopy. In our experience, adhesive processes or bullae of the eardrum should be dilated at least 2 times before performing fusion or reinforcement surgery by inserting a cartilage chip. So this is very important, especially in children. Multiple dilatations can regenerate the eardrums so that surgery is no longer necessary afterwards. Close to 80 up to 90% of patients do have a benefit from tuboplasty, especially in children. This also represents a highly significant reduction in complications in adolescence and adulthood. The question of why tuboplasty is not successful in some cases cannot be yet answered. This may be due to user error, first situation, or a multifactorial problem. So after a single unsuccessful tuboplasty, tube dilatation, the procedure should definitively be performed a second or a third time, 2 or 3 months later. Diagnostic, especially preoperatively diagnostics, can be reduced. Keep the things simple. The disease factor is the complaints, first of all. In summary, tuboplasty is a very simple, when you are experienced enough, and a safe procedure to successfully treat eustachian tube dysfunction, especially in children. And the Spiegel and Theis tool is a very nice, helpful, and successful tool to do that procedure. Thank you for your attention. And if you have now any questions, do not hesitate to ask me. Thank you.
Thank you, Euteneuer, and thank you very much, Professor Tisch, for your 2 presentations. It's always a pleasure listening to it and to get more and more information, especially for me. Every time I listen to BET presentations, I learn something more. And this was very specific to pediatrics and children, and I really enjoyed listening to you. Well, thank you very much again. And even though you dived so deep into the whole material, we did receive quite a few questions from the market, from all over the world, from Brazil and the other side of the globe, which we would like to address now. And I'm very happy to hand over to my colleague who dialed in from London. He will take care of all the questions and address them accordingly. So Dan, welcome to the group. And yeah, it's your microphone now.
Thank you for the introduction, Matthias, and thank you, Dr. Euteneuer and Professor Tisch, for the very informative lectures. And hello, everyone, from a rarely seen sunny day in England. So we've had some fantastic questions that I think would be helpful for us all to go over. So I'll direct these questions to both Dr. Euteneuer and Professor Tisch, and please feel free to answer these. So the first question is, at what age can dilation catheter be inserted in children? And either of you can give your opinions, and if you have something additional to add, please do so.
Thanks, Gwen.
Yeah, I can do that. So in my hands, I usually start at about 4 years of age. So the youngest I've done so far is a 4-year-old.
Yes, in my experience, we can start from 2 years. So I'm a little bit more experienced than Sarah in young children, of course, because we started a little bit earlier. Younger than 2 years, I do not recommend because of missing anatomical orientation. But if there are special cases, so I agree to Sarah, the best age is 3.5, 4 years. But in special cases, when there are a recurrency of otitis media 8, 9, 10 times a year with antibiotic treatment, it should be in your mind to think to a tube dilatation as an alternative approach to optimize the drainage from the tube.
Thank you. So this question, I guess, reiterates the purpose of this presentation, but I think it's still something a lot of people are asking. Are there any surgical risks associated with the balloon dilatation in children?
Should I start first again? So basically nothing really major. You have to be careful when you insert the catheter as well as your endoscope not to lesion the mucosa on the turbinates as well as on the septum. So basically nosebleeds is the only really issue that came up. And once again, as both of us have stated in the talks, you have to be careful with the insertion device and your catheter to make sure that you really see the rear tip and you're not pushing it fully in, so that you, and the risk where I'm seeing lesioning or entrance to the bony tube or the middle ear is when your catheter is not inflated. So basically right at the start of the procedure, there you want to make sure that you consider in your head how long the catheter is and how long you want to go into. And if you keep that in mind, I don't think that injury to the middle ear is an issue in children.
So the next question is, in your experiences, how do you access with the balloon when there is an obstruction? One of the examples is, for example, adenoids, and you don't have much space.
I think, as I've told you in my presentation, it's according to plaster. First the nose, second the tube or the ear. The endoscopic examination of the epipharynx, and it is possible even in young children, is the most important approach to be sure that there are no adenoids and there is no anatomical barrier, so not to perform the tuboplasty. So the most important point is diagnostic has to be correct.
And if I can add to this, when I talked to the parents before the procedure and I wasn't able to really thoroughly examine the nasopharynx in the child, I'll tell them, look, I have no idea if I really get to do the balloon dilatation in your child. I have to see the nasopharynx first. And if there's adenoids, it will be an adenoidectomy or a revision adenoidectomy. And then we'll see how we go from there, and the dilatation will come up later on. So adenoids first.
Yes, and an additional point is that there is no indication for a combination of adenoidectomy and tuboplasty in the same step. So first of all, the adenoids has to be removed. You can combine surgery with a local cortisone spray for a couple of weeks, of course. And to be honest to you, more than half of the patients are cured after this procedure. So we want to indicate the tuboplasty to these patients where the established therapy approaches does not fit. And this is the point, then the indication is correct, and then you will have success in these patients.
Fantastic. I think that should make sense for everyone. Another thing which was already covered, but I think if we're getting these questions again, maybe it's good to clarify. So what are the common complications for balloon eustachian tuboplasty, and how would you manage them? Either of you.
Yes, I can do. As I said, nosebleeds are the only real thing that comes up. As Matthias Tisch has had his one emphysema, I had one myself as well. So luckily that was adults, because in those patients or even teenagers, you can easily tell them to stop doing the Valsalva maneuvers post-operatively and to stop the breathing. And we did a common publication on that back in 2014, I guess, and all our patients that we summarized in Germany healed spontaneously. So nobody needed any tubes or progressed to the mediastinum or really had issues. So stop blowing the nose. If you have any hints for an emphysema in your clinical observation, and if you feel like it, you could prescribe antibiotics in that situation. But even in the patients where we didn't, there was no problems.
I've never seen any serious complication, even in young children, by using the correct device. This is the most important point. So there is no reported case in the literature, just known to me, when the correct device was used, that there was a serious complication. So we do have complications, of course, emphysema, nose bleeding, and no exact anatomic orientation, of course, but a serious adverse reaction I've never seen.
Thank you. So I think maybe to help put people's minds at ease, both of you could say how many procedures you've done. I know you said the complications you've seen are very rare, so maybe that could help everyone to understand. If you can tell us how many cases, BET cases, you've both done.
I've performed more than 2,500 children and more than 10,000 in the meantime. I think nearly 15,000 tuboplasty in adults in my clinic in the last decade. This is a normal routine procedure. We combine tuboplasty, especially in patients with cholesteatoma, to have a better situation for the ventilation of the middle ear after the surgery, because the question is, why does a cholesteatoma develop? And so the reason in most of the cases is the tube. So to combine or to make a combination of these both approaches does make sense, in my opinion. And summarizing all these cases, once again, I've never seen serious adverse events, and it's a very safe procedure. To be kind to the tissue would be kind to the tissue would be kind to you. So this is the most important step.
So not a small number of cases then, not a beginner in this then.
I do not recommend to start with children in the first 100 cases. Never ever, because you have to be experienced. You have to know what you are doing. You need correct orientation, as Sarah told us, and this is the most important point. Thank you, Sarah, for that. Yes, you have to have your orientation between the catheter, the end of the catheter, the insertion tool, and the fossa, and this needs, I think, 50, 60, 70 cases to be sure not to go too deep inside, because especially in young children, the approach to the fossa is very wide. And when you go in with the insertion tool too deep, the distance to the bony part is not 18 or 20 millimeters, it's 5 millimeters. And these cases Sarah told us about, where the catheter, the tip of the catheter is passing through the cartilage part, the bony part is passing the middle ear, and then you have a defect in the eardrum. So this happened, but this is only in cases when the surgical experience is not enough.
Great, thank you. And perhaps Dr. Euteneuer, you could also give your experience, because of course people are interested in the very low amounts of complications, and probably if you say your amount of experience, it would ease people's minds.
Well, Matthias has done many more than I have, and that's basically resource allocation. I have to get the surgical spots, right? And usually I would say I would do one child and about a couple of adults every week. And I started back in 2011. I stopped counting, I have to admit, by 2016 at some point.
Fantastic, thank you. So the next question we have is, which angle would you recommend for the insertion tool that would be better for kids, and what would be better for adults, if there is a difference?
To me, there's none. I usually use a 70-degree endoscope on the opposite side, and then I can view the whole nasopharynx. Once again, if I then see adenoids, it's the adenoidectomy and not the balloon dilatation. And so if I can visualize the opposite eustachian tube, I usually take a 45-degree insertion device.
So you see, in this case, two very experienced guys, yes, two different approaches. I use only the 30-degree endoscope because this fits better to me, of course. And I use the same insertion tool, so 45 degrees, and I do not need another ankle. I never saw a situation where this normal insertion tool does not fit, and that's all. So keep it simple.
Perfect, thank you. Another question which might be good to address is how many times can we repeat this procedure, and how long can the gap between the two procedures be? So please answer this question however you think would be best.
Matthias, would you like to start?
Yes, okay. So in my experience, it does make sense to wait at least 3 months. So earlier than 3 months, it does not make any sense to repeat the procedure. When you are in the beginning, and when you are not sure that you have been in the eustachian tube, so you do not have any effect, no positive result, and the anatomic orientation was very bad, was worse, yes, then perhaps you can repeat it once again with an experienced guy on your side. But normally after an successful procedure, after 3 months at the earliest. I think, but this is under discussion, and Sara will say something to that topic. 3 repetition tuboplasties are the end more does not make sense, because we do have in these 20% of the patients effects we can't explain, and it does not make any sense to repeat it 5, 6, 7, 8 times.
I would agree on that one. So in the children, or in teenagers and adults, if people come back and ask for a revision tuboplasty, I usually try to ask them if they had initial benefit from the procedure, so about 10 days, 2 weeks after the procedure, that they could really hear a clicking when they were swallowing, or if they could do their valsalva much more easy than before. So I'm looking for initial success that then tapered or faded away. If that's the case, I'm really willingly to offer a redilatation. If there was no initial success, that usually makes me think about my diagnosis and if I missed something. In teenagers and adults, that's usually chronic mandibular joint disorder. You really want to look out for that. And the other thing then would be allergies. And as you mentioned, Matthias, if someone comes back and wants it 4 or 5 times, I bet that person is allergic.
Thank you. So another question would be, do you routinely perform CT scans pre-op, or have you ever done this? So that's for the both of you.
Sara, would you start?
Yeah, in the beginning, back in 2011, we did CTs in everybody. Then we stepped back and only did the CT scans in adults with a one-sided problematic, because we didn't want to miss that tumor or anything. But honestly, in all those years, I only found a couple of tumors and 1 aneurysm of the carotid artery, and that was it. And nothing more than that. And in children, obviously, to the radiation impact of a CT scan, I don't do it. And only MRIs, and if that's necessary in really, really rare cases. So not routinely.
So I totally agree. There is no indication routinely perform a CT scan or an MRI, but there is no indication as well to switch off your brain. So when there is a malfunction of the eustachian tube, you have to have in your mind that there are different reasons for this malfunction. And the drainage is one of that, but there are other reasons. And when you perform 1 tuboplasty and there is no effect, as Sara told us just a couple of minutes ago, yes, then there is no indication to repeat this procedure without further diagnostics, yes, because then you have to have in your mind that there is an alternative reason for that malfunction, and then additionally diagnostic is needed.
Great, thank you. So the next question, and we won't have too many more. The next question is, so chronic chronic rhinosinusitis may accompany otitis problems also in children. Do you recommend simultaneous treatment of the sinuses, maxillary balloon in those cases?
Honestly, chronic rhinosinusitis in my clinic so far hasn't been a big issue in children, except cystic fibrosis kids. But otherwise, a sinus disease might be the same beast as eustachian tube function. So it's the same mucosa, right? I would, or in the adults at least, I do the sinus procedure first, and then I wait 3 months. And if then the ear is an issue, then I usually do I offer the dilatation. So sinus surgery first.
So once again, the old things are good things. So Blaster told us, first the nose, then the ear. And so all is answered. So when there is a chronic sinusitis, you have to cure the chronic sinusitis. And I think more than 85% of these patients do not have any longer any problem with the tube. But when there is a chronic malfunction of the sinuses, yes, there is a big influence to a tube malfunction. And it does make sense when the treatment of the chronic sinusitis is ongoing, is running, yes, to combine it later on with a special tube approach, yes. And this might be a tuboplasty, of course, but first of all, the drugs to treat, even mometasone spray, the local steroid spray, is the same in chronic sinusitis and in the tube, and this is why most of the tube malfunctions are going away with a correct therapy approach of the sinusitis.
Great, thank you. So the next question, it's about combining tuboplasty and tympanoplasty. Do you think there are situations where this would be a good idea for both of you?
For cholesteatoma, I might do it synchronously, but as Matthias emphasized, if the indication, especially in a kid, is an adhesion process, I definitely go for the dilatation first. And there's more than a handful of kids where there was no need for tympanoplasty anymore whatsoever after successful dilatation, and patience for half a year, because then that's about the time that the tympanic membrane needs to kind of tension up. I never saw that tensioning in adults though. So it's really something for the pediatric population.
In adhesion process, I agree totally. Of course, once again, Sarah, thank you. So we do the same approach. So first the tube, and then to wait to optimize the drainage of the tube by a Tubavent balloon or by Valsalva maneuver, if it's possible, and then to wait. Especially in young children, we do have a very positive result in these cases. If there is a persistent adhesion process, or if there are persistent bullae of the retraction processes or retraction pockets of the eardrum, yes, and we do not have any result after the first tube dilatation, and there is a need for a tuboplasty to bring in a cartilage, for example, it does make sense to repeat tuboplasty in the beginning of the tympanoplasty, because then by insufflating the middle ear, by bringing in the pressure of the air, the eardrum is coming out a little bit, it is separated from the promontorium bone, and it's much more easier to separate the eardrum, the epithelium from the eardrum from the promontorium, because in other cases, you know all experienced middle ear surgeon knows this situation. You try to separate it, you make the operation after 5, 6, 7 minutes, you look via the microscope in the middle ear and you think, oh, where is my eardrum? My eardrum is no longer existing, it's gone, yes? And this is much more easier to bring in, once again, an insufflated balloon, to wait 2 minutes, and then it's separated, it's coming a little bit up, or the bullae are coming out, and then it's much more easier to perform tympanoplasty.
Fantastic, thank you. So I think this was already covered, but I think this is probably the biggest fear that surgeons have with this procedure. So I'll ask this question. Is there any known report of carotid artery injury in children or adults?
None that I'm aware of.
Once again, when you use the right tool, And when you use the accepted catheter for this procedure, there is no known case. So there is a case in Berlin, but that guys there used a wrong catheter. Yes, and so the pressure fits not to the bony part of the petrosal bone, and then they hurted the carotid artery. And this case is reported all over the world, but it was a wrong approach and it was a wrong catheter. And this is the most important point. We have made some biomechanical exercises in the lab. And so first of all, we published a study how thick the bone of the carotid artery is. Yes, and it's according to Gauss, it's from 0.2 up to 2.5 millimeters thickness on both sides. Yes, and then we tested how many pressure is needed to destroy 0.2 millimeters of concentric bone. And you need 150 millibars, and the catheter is destroyed by 15, 16 millibars. So it is not possible when the bony part is intact to destroy it and to have a complication with the carotid artery. It's impossible.
Perfect. Thank you. Very clear. Another question. So have either of you had experience with balloon eustachian tuboplasty alongside T-tubes, or have you done this yourself previously, or maybe you could both give your experiences?
Well, I guess I did in the talk already. If there is a effusion, I do at least the paracentesis, and if the effusion that I suck out is really, really mucoid, and then via the incision, I can see that hyperplastic, swollen, hypertrophic mucosa. This is when I put the tube in conjunction with the balloon dilatation, and that might play into safety as well. If I see an effusion, I do the ear first. Because barotrauma to the middle ear, if you have a non-compressible liquid inside, might come to some people's heads as well. So then I do the paracentesis and I put the tube. But once again, the tube is not causal treatment. It's symptomatic. I want to make sure that that mucosa heals down. Then afterwards, I do the balloon dilatation. And that's the causal part of the treatment.
Thank you. I guess we have time for a couple of more questions. So is BT in cleft children contraindicated?
It is not contraindicated, but the reason for the malfunction is not that what we have talked about. So there is an anatomical problem, of course. You can use that as a last step, because sometimes you do not have any other surgical procedures in the bag. We did that in the past, and only a third, not only half of the patients had a benefit from this procedure, but there is no contraindication.
Great. So my final question. So this is about Valsalva maneuver post-op. Do you have a recommendation from when they should start doing this, and how often?
I allow them to start 6 hours after the procedure.
We do it a little bit later, so the next day, so 24 hours. But this is in the experience of the surgeon. Coughing and sneezing is a bigger problem, and to inform patients that they have to open the mouth does bring better results. So if there are micro injuries of the tissue, it might be a small risk, but when you perform the intervention correctly, you don't see any problems.
Okay, thank you very much. So I'll hand over to my colleague Matthias, and thank you very much.
Well, yeah, thank you, Dan, for managing and directing all those super interesting, open and plain questions. And of course, Thank you, Dr. Euteneuer and Professor Tisch, to answer those questions. The questions were pretty detailed, and they show a very high interest in this topic. And I think we could talk about this for hours, but I think we are already a little over our set time schedule. So again, thank you very much to all of you for sharing this very precious and interesting information and for taking your time. Well, thank you for that.
Our pleasure. Thank you for the invitation.
Our pleasure.
Thank you. It was my pleasure. The pleasure was on my side. Thank you, and have a nice afternoon and a nice weekend to all.
Have a nice weekend too. Thank you.